Yeah, thank you all four speakers for addressing the two-step approach. I think you have seen that on the one hand, there is a large consensus that we should treat early. However, we learned that this is not the case everywhere in Europe, that there are some differences even between the clinicians. For instance, in Germany, they are very active to treat early. In the Netherlands, it's a completely different story. Many neurologists treat late with the newer substances, and that are the face, or we are faced with these different treatment approaches. And on the one hand, I can understand very well that you are saying these are individual decisions between the doctor and his patient. However, we as regulators don't do this individual decisions, so we have to focus on the generalizability and the whole population. And I think that sometimes makes understanding of each other difficult, particularly when we are discussing with patients. However, the last data that patients would stand or would accept risks for high efficacious treatment is a strong message to us as regulators, and of course we will consider these things. So, discussion points. Who wants to start? I think you have been first.
Christoph Thalheim from the European MS Platform again. First of all, thank you, Gavin. That was a wonderful presentation, and I couldn't agree more with what you have said. Secondly, I would like to remind all of you of the session which happened, I believe, in the same room here a couple of years ago regarding Tysabri and the risk-benefit assessment. And we had a colleague there from my board who said, it was Alan Connor from the Irish MS Society, who said that he would prefer to add life to his years rather than, or not necessarily, years to his life, which goes in the same direction what others have said here, that the risk willingness by patients is often much higher than the experts are assuming. At the same time, I would like to share an interesting anecdote with you to the same issue. I was thinking exactly the same what Alan O'Connor said, and I thought that the vast majority would be in favor of taking the risk if in return they would get higher quality of life for a certain number of years. When I traveled to Poland recently, I asked to about 45 patients in a clinic there, MS patients, the same question. And it was a theoretical question because, as most of you probably know, Tysabri is not available, and the average between an MRI assessment and the first date of a visit with the neurologist is about 18 months. And about 10% of the people who should be treated are treated there. But that's another story. What came out of this question to the patients was that there was a majority who was not willing to take this risk of Tysabri once it was explained to them what the risk would be. And we discussed further and tried to find out why would that be different in Poland than in other countries? And we came to the conclusion it must be because Poland is a very strong Catholic country. So the influence of another social factor, religion, to this decision was something completely new to me and probably to most of you as well. Thank you.
Yeah, thank you for this important comment. Something to add from your side?
No, I just think that, not only the risk-benefit of the drug, it's also the risks of untreated MS or poorly treated MS. So I think we need. One of the things we've done as clinicians in the past is we haven't told the whole truth about this disease. people with the disease don't know the impact it has on their employability, their relationships, their cognition. And I think if we present the information about how damaging this disease can be at a subclinical level, unfortunately, we got our blinkers on in terms of EDSS. We think of MS as a disease that affects walking, and we think of the disease as walking sticks and chairs. But long before that happens, this disease is very disabling. And I think that's the message I'd like to get through, is that there is a window to protect the brain. And what we haven't discussed is aging. All these people with MS are going to get older one day. And they're going to get Alzheimer's disease, and they're going to get vascular disease. And we now know that if you lose cognitive reserve, or you have you're not going to age very well. So we also have a responsibility, if we have treatments that can protect the brain, potentially protect the brain. People with the disease should have the option of choosing those treatments. I'm not saying they should necessarily take the risks, but they should have the option of choosing those therapies as first-line treatments.
Yeah. So, Klaus?
Yeah, just comment. Having said that, I think we should realize that although these treatments are highly effective, there's only going to be a proportion of people who respond. There will be, there's side effects. So I think there is sufficient ground for certainly head-to-head studies, rather than sort of having them sort of further down the line. And I think you made that point very, very nicely, Hideki, in your presentation. What it means to go sort of down the corridor, miss the boat, or lose a lot of brain along the way, and then, I was about to say having a harder time, but actually having no time to recover what has been lost.
Yeah, I think that is one very important point for us as well, so that we see in data that patients are not catching up when we switch them to the more efficacious drugs. Well, as I mentioned earlier, it is a risk-benefit ratio. In mild disease, there should be mild risks to be balanced, and that is our daily working as regulators. And so, on the other hand, you have seen that we are able to readdress issues, and as we did with the alemtuzumab, where we accepted the parallel approach. George, you have been next.
So I've got a number of comments. I think that if you look at, we're assuming that MS is caused by a secondary autoimmune response, and experimentally trying to suppress a secondary immune response is very difficult. You almost have to kill the animal to actually suppress a secondary immune response. It's the way the nervous system, or the immune system is designed. And so the idea that somehow you're going to be able to suppress a secondary response and not pay a price is very improbable, very improbable. There's no animal sort of parallel for that I know of. So I think that the fact that there were problems that occurred with natalizumab wasn't a surprise to everybody, I have to say. Now, Gavin's given a very bullish sort of perspective on early treatment, and I think it must come from having spent a very long time observing the natural history of the disease without any treatment, because there wasn't anything available, that I would make the following points. I've seen several patients who are like the ones that Gavin described, who had no treatment. And so people can have a bad time of things and then still get better. I think that the cognitive data that was presented has to be considered in the light of the long-term follow-up of the original beta interferon patients. So at 21 years, 50% of those patients who had already had the disease for 7 years, so at 28 years of disease, 50% had no detectable cognitive impairment. So it's very improbable that the data that were presented could possibly accelerate that quickly. Now, that was with a detailed cognitive battery that was done by one of our neuropsychologists here in the UK, Don Langdon. So I think that the problem is there's suggestive evidence that treating early may be beneficial, but the other side of the coin is that some of those patients are going to do well, and do well over a long period of time. And what we don't know is what the long-term consequences will be of some of these therapies. And we have some idea that there could be a problem. Immune surveillance is involved, obviously, in reducing the rate of malignancy, and immunosuppression increases the rate of malignancy, and so on. So it's going to be a complex task, and I think that the important thing is that if people are going to embark along these lines, that patients have to be made aware of these concerns.
Yeah, thank you for this comment, which, Serge, on the clinical picture as well?
We all know that MS is certainly a terrible disease, but I think it's not really necessary to add additional fears. I must totally disagree with the last speaker regarding the stating MS as a potential dementia. It's totally unfair and untrue to state like this. I'm seeing both MS and Alzheimer's disease and related dementia, and there's a clear and evident difference between those two conditions. By applying the usual definition of dementia, less than 5% of MS patients will fit with this definition. So it's totally, I think, it's not serious to state that MS is a dementing disease. Certainly, MS will be associated with some degree of cognitive impairment, but dementia is a very serious condition, and most MS patients won't be demented. I think this point must be stated certainly with strength. The other point is the impression as a chair of the SAGA of the position of patient representative. For every last meeting, when we have to provide some advice to CHMP regarding new drugs, we had representative of patients. And I must say that in each meeting, patients were extremely attentive to the risks, and in most situations, they were willing to accept risk when their condition was serious, and mostly when they were escaping to the usual first-line treatment. And they were prone to accept risks for the first-line treatment as soon as we were coming with sufficient data on efficacy and providing them many information, reassuring information regarding the risk. So in many situations, I must say that the patient representative would be more prone to accept the two-step than the parallel one. It was my feeling from the patient representative who were there. And I have very precise example from the last drugs we have to assess.
Other comments, Klaus?
Yeah, just one comment, perhaps. I think maybe we should be a little bit more sort of evidence-based on that end as well, and look at the data about sort of the preparedness of patients to take a risk. I think the data that were in the paper I referred to from 2009, I think is probably more valid, in fact, than a single comment by the single representative of the MS community, albeit, a representative, but still it's only a single person. The second comment, I think, is that when we're looking at rheumatology, that patients are being treated early now. And I totally agree with George. There will be the odd or occasional patient who does not necessarily require treatment, no doubt. I mean, despite us finding out more and more that the condition benign MS is probably rarer than we thought, there still may be the odd case. But I wonder, is that really a valid, is it right then not to treat all the others that would benefit from treatment? in favor of that one who doesn't need it?
I think for us as regulators, the issue is, as George mentioned, there are 50% or up to 50% of the patients who are doing well over a long, long time. And if we are treating all these patients over a long time with these highly efficacious drugs, we all know these case records that patients suffering from cancer after long-term immune modulating drugs. These are case records. However, if we are going to a very broad population over a very long time, I think we will see more of these things as well. And we are trying these things to balance in our approach. On the other hand, asking the companies, is it more a question of the sequence? So what we are trying to avoid is that you start with the mild cases and that we see the data on the mild cases, and then we never again get the other data from the more advanced patient population. So if you do it in parallel, is this a solution as you proposed? I think we would reconsider that. But the requirement is we need, from a very broad patient population, then clear clinical data. We really fear that it goes the other way around. If you start only with the mild cases, there is something, and then there is a conditional approval, and then due to ethical reasons and so on, you will not be able to follow up, and we never get the data. Andre.
I only can repeat it. We should really realize that if you look at the clinical trials in multiple sclerosis, that in the recent trials, the patient population is much milder than in the earlier trials with Avonex and the beta-frons. I think the baseline relapse rate, well, over 2 years was 1.2 to 1.6, and now it's 0.3 to 0.4. These are mild patients, and this might be due to the better diagnostics, especially by the introduction of the magnetic resonance. And we should realize that if you look at natalizumab, if you look at alemtuzumab, even if you look at fingolimod, they are in practice, and also at least in the neurological treatment guidelines, they never are first choice. Actually, it might be a patient who is very rapidly evolving from the beginning. But at least in the Netherlands, I think 50% of the neurologists still are prepared to wait in a mild patient what happens before they start treatment, even better front. And we should not say that, okay, patients are restricted so they don't get the right treatment. They will, in first instance, they will get beta-fron or glatiamine. And I admit, I agree that the shifting between those class of products in a patient who's unresponsive is not very useful. But in the next couple of months, we'll get dimethylfumarate and we'll get Albadia. So these patients are not. There should not be an impression that patients are not treated if they're not switching immediately to fingolimod or natalizumab. And there are mild patients, so there is a kind of hierarchy in first choice of treatment. And I think Carl is right. What we see, if you do a trial in a broad population, we don't get the data for the patients for efficacy in highly active disease because that is a small subpopulation. So I think we need this data. I think we should realize that.
Please.
One of the problems we have is that because of the way the drugs are licensed, is that we have to rely on clinical activity to define disease activity. So in the UK, we can only really escalate if people are having relapses. So if they've got no relapses, they may have an MRI activity that's very active and they're losing brain. Unless they're having relapses, we can't escalate. So it depends what you mean by benign. Are you talking about no relapses, relapse-free, or lesion-free, or atrophy-free? So you see, the thing about MS, it's like an iceberg. What we see above the surface of the water is very little of what the disease really is. It's happening at a microscopic level. And so by the time somebody fails using our current definitions of failure in our guidelines, you know, the thing about the brain is very plastic. It's got reserve. They compensate, and then all of a sudden they stop compensating, and they're in the progressive phase of the disease. And if we had a treatment that may have worked early on, we've missed the boat. The horse has bolted. So that's the problem with our current guidelines, is that they don't appreciate that our clinical monitoring is just not good enough, simply. It's not good enough.
Do the clinicians agree to that?
This is Carmen Bozic, Biogenetic. Just in terms of the commentary, I do think we need to separate out sort of the drug development process and the two-step approach there versus the practice of medicine. And the guidance is really around the drug development process. And we did outline that if we do rigidly adhere to a two-step approach, that we will have a delay in the approval of an important therapy in MS patients in Europe. And that's something we'd want to avoid. And that's another important consideration in using the parallel approach. The other thing is that you want global harmonization in approaches as well. And so we do have to be very mindful of that. You know, the FDA, other regulators aren't necessarily advocating for a two-step approach. So, and we do global drug development. We'd like to do our pivotal studies in a way that's relevant for all major regulators. So that's an important thing to keep in mind. I do hear your concern, though, that you want to have efficacy and safety data in both populations, the mild naive patients as well as the pretreated population. But a parallel approach would actually get to that aim and get to it much faster than a sequential approach that you're advocating.
Okay, thanks. Others on this?
Yes, Gord Francis from Novartis. I think one of the issues that we're not, and I think Gavin mentioned this, is that nobody's mandating that an early patient must go on to these therapies, but that one provides the option for them to go on to those therapies should they make that decision, in conjunction with their physicians. So I think that's a subtlety that we shouldn't lose track of. The other thing about getting a broad enough patient population, I think all of the studies that have been done have actually had relatively broad populations. We'll come to characteristics a little later on. But particularly in certain regions like in the U.S., you almost don't get a naive patient because everybody's been on a therapy, so they're all treatment failures or moving off anyway. Maybe less so in the European situation in terms of the breadth of use. I think the other aspect is there's always the post-approval setting in which if there's a patient population that hasn't been studied or hasn't been studied adequately enough, then that could be built into there as a post-approval commitment or as a conditional approval with additional studies required. I think no one's trying to say we should ignore just sort of drive ahead irrespective of any safety issues, but just leaving the potential for people to access the therapy should they make that decision. I think the risk assessment issue that was outlined there. I think we tend to be, maybe a little paternalistic at times, trying to protect people, but maybe people don't want to be protected, and they'd like to make their decisions based on their own personal situations.
Yeah, thank you for this comment. George.
So one comment about asking patients of what risks they're prepared to accept. This has been studied a lot in a variety of different diseases, and it often breaks down by personality. People who are gamblers and so on, risk takers, are going to say, what the hell, I'll just do it. And then the majority of people actually are somewhere in between the extremes. And some people don't want to take any medication for any reason. And so that's part of being a physician, is to try and figure out, where this individual sits in, trying to make a decision, helping them make it or doing it that way. So I think that, one has to take the patient's own perspective on this in mind. I don't think we should be necessarily trying to force decisions on people. So.
Yeah, and it's clearly not our intention to influence this individual decision-making between the doctors and the patients. Please.
Just to respond to George's comments, Ed Holloway from the UK MS Society. I don't think we are advocating a forcing of a risky approach, but giving people that option. And if the regulators are restricting people's options to take riskier treatments on an informed basis, I don't think that's what people with MS would want in general. Not everyone will want to take riskier treatments, but some will.
But what people say, or what they say they wish to have, is very much influenced by the way in which it's presented by the physician. And most people who've been in practice for a long time are convinced that for the vast majority of people, they could talk them into either option very easily, depending on the way they phrase it, cup half full or cup half empty. And so physicians have to remember that they have a huge responsibility and they can easily tilt the balance just by the manner in which they say it, the enthusiasm with which they convey it, and the way in which they emphasize the side effects versus the benefits.
I'm sure you're right, and I think there's a role for organisations like the MS Society to provide additional information and decision support tools that can help that decision. But I still think that decision needs to be made at the clinic level if we're unfairly restricting choices, simply not giving people the option to take a riskier decision on an informed basis.
I think it's only a sequential approach. We don't withhold treatment options over a long time. So it's a question of balance, I think.
We've heard some evidence, albeit not accepted by everyone, that sequential approach may have a longer-term adverse impact on outcomes. So I think I accept it's not completely withholding treatments, but it is potentially having an impact, and it is restricting choices. Clearly, regulators always need to restrict choices to some extent, but it's important that we get the balance right. And I'm not convinced that we understand well enough the risks that people with MS are prepared to take.
Yeah, and we have regulatory approaches to deal with that. So we accepted alemtuzumab and in a parallel approach. On the other hand, we learned our lessons from the Tisabri, and so we have to see the general population, and can it be translated then to the general treatment what we approve. And there are risks if we are too reluctant or too liberal. And I think that's our job as regulators, to be sometimes more on the conservative side. However, I think that we have this meeting today should show to you that we are reconsidering all these issues and that we are open-minded here. And I think Klaus made the statement, do the regulators think that for mild patients we have enough options? No, we don't think that. So it's, as I told you, we are coming from the benefit risk assessment, and our concern is, should we start in naive patients already with these highly competent drugs when we have so many other options available today? So, and we don't have the comparative data, which is the best to start, or how much is lost if we start with this drug and switch later on to the other drug. And that is not in our regulatory field of approval to ask for these comparative trial data. However, we would be happy to see some or more comparative data and active controlled trials. So I think...
Amy Bowen from the MS Trust. Just listening to the conversation over the day and thinking about the people with MS that we speak to all the time, the question that they regularly ask us, oftentimes very shortly after having seen their neurologist, is, you know, I was given a whole bunch of information, but I don't know what it means for me. Nobody seems to be able to tell me what benefit I'm going to derive as an individual from the choice that I make. They tell me about the risks, but they're much less able to really tell me with any real degree of accuracy about the benefit. Over two horizons, over the relatively short horizon, you give some idea about, you know, likely reduction in relapses, but not with a very, very high degree of accuracy. And over the long term, very, very much less specificity in terms of individual benefit. And the other point that I'd like to make really is that lots of people with MS don't get access to a neurologist who has a good level of understanding about MS. Lots of people with MS do not see MSologists. They see a general neurologist, and they don't have the benefit of the kind of rich conversation that they rightly should have if they're talking to somebody who's an MS specialist. So they think there's something going on about the underlying services as well, and making sure that we are perhaps adopting a culture that's a little bit more like the culture in cancer, that says, you know, not you've been diagnosed with MS, let's give you a little time to get used to your diagnosis and see how things unfold, and then we'll talk about whether disease-modifying treatment is appropriate. You would never accept that in cancer. No one would ever say that to somebody with a diagnosis of cancer. They would say, this is a lot for you to take on all at once, but this is the diagnosis, and let's get on with treatment because we want to do everything we can to improve your long-term outcomes. And I think there's a deep culture shift that certainly needs to happen in the UK, and I suspect also needs to happen other places.
But hearing your arguments is for us as regulators even more concerning. If they are not the right experts to deal with the patients.
It's not that there aren't the right experts, it's just getting patients to them.
Yeah.
They are there, but it's making sure that the services are configured in such a way that diagnosis is done by a general neurologist. But, you know, we would argue from that point onward, the right place for somebody with MS to be is talking to somebody who specializes in MS.
So from our experience with the SAC discussions, with our exchange with academia and scientific advice experience with pharmaceutical companies, we are not that pessimistic. So we think that the field in multiple sclerosis is well organized and that people are knowing which options they have, and that the doctors or neurologists are well educated in most places of Europe. So that was our impression from, however, every system is improvable. No question about that. Klaus.
Yeah, maybe just one comment about sort of, I think that the whole sort of communication with patients is, I mean, still changing massively. I mean, over the last 20 years, through social media, through, I mean, provision of the internet, obviously a younger generation of doctors coming through as well, I think, who are generally, I think, prepared to have a more, I think, an interactive and sort of equal level approach to decision making, and I think that impacts on how, of course, how patients will, or people with MS will then take their decisions. So what George said about you can sort of tilt or tip them either way, I'm not so sure. Maybe it's my lack of seniority in that respect, but I'm not so sure that this is going to last for very long. Or I mean, I see many people who are well informed, and they go to, you know, sometimes they have contact with several neurologists, and so they get their opinions in, they draft the information from various sources. So it's not sort of me and them, and then they see me once in, I don't know, in a year and a half, I think was mentioned earlier. So I think they're pretty well informed. I had a question, maybe there's a sort of a basic misunderstanding about sort of the role of the EMA here, because maybe it's also to do with how we discuss this topic about treatment. I think you mentioned it earlier. So the treatment decision in practice is one thing, and the trial design and what we need to do sort of to, you know, to satisfy the regulatory authority is probably a separate thing. But I think it all gets a little bit mixed up, and I wonder, I mean, to what degree the decision should really rest essentially. I mean, once sort of safety, I mean, the whole sort of profile of a drug has been established, to what degree that should then rest in the interaction between the doctor and the individual with the disease.
So we don't influence the individual decision-making process between the neurologist and the MS patient. However, it is our responsibility how we label the drug. The labeling will be based on the clinical trial data, and it's our job to look that these labeling can be translated then in everyday practice. And we have been criticized that even our labeling for Cisabri is not understandable to the patients, even to neurologists. And so we are thinking a lot about these things, and so there is a clear interchange. So it's our job that the labeling then in the end can be translated by every neurologist. And this is something, as we are using complicated biomarkers and their interpretation, if these techniques cannot be used to make a treatment decision then in the general practice, then it might be difficult to accept such a biomarker. So these are the issues where is an interrelationship. However, to refocus it a little bit now, I have seen your concerns that a classical two-step approach, strong sequential, is not favored by the pharmaceutical companies or some physicians, even patient representatives would prefer faster access. However, I think we can reconsider this approach. As I mentioned earlier, what we need is then sufficient data for both patient populations to make our decision on. So I think with the new European legislation, we have the armamentarium to go over a conditional approval, to do after-marketing authorization, now efficacy and safety studies, and to require these data. Is that a fair summary? Okay.